Welcome, everybody. Happy Friday. I'm looking at my weather app here and it says it's exactly 70 degrees right now in Seattle. So we're definitely having a happy Friday. So thank you all for logging on today for Grand Rounds presented by the Department of Psychiatry and Behavioral Sciences. My name is Jed Thompson. You might know me as the Associate Director of Communications for the department, or you might know me as the Grand Rounds host, or you might not know me at all, in which case, hello and nice to meet you all. We have a great guest here today to speak with us, Dr. Peter Vitaliano. But before we begin with that, I'm going to give some people some time to log on to the presentation. So I'll go over a few logistics with you. First, I did want to mention that this presentation is sponsored by the Garvey Institute for Brain Health Solutions. You probably heard as you logged on that we are recording today's presentation. So this will be posted. We have a Grand Rounds archive on YouTube, so we'll be posting this shortly after the presentation ends, if you'd like to watch it again. We also have a survey if you'd like to provide feedback. That will be available to you as soon as the webinar closes. So once it ends, watch for a link to that survey. We'd love to hear your feedback. What else would I like to mention? We are hopefully going to have a little bit of time for Q&A at the end, but no promises. If we do, we're going to use that Q&A feature at the bottom of the webinar there. So at any point during the presentation, if you have a question, go ahead, type it in there into the Q&A. I'll have those queued up if we have time at the end. If we don't have time, Dr. Vitaliano has been very generous and offered to he's welcome to being contacted by email. So if you want to give us your email address and your name, we can pass that along, and you can interact over email and have your questions answered that way. Okay, so this is our last Grand Rounds of the academic year. So we'll be taking a break for the summer after this. So once again, thank you for being here. So I'm going to disappear here in a second, and the chair of our department, Dr. Jürgen Unitzer, is going to introduce today's speaker. So I will wrap it up here for me, and Jürgen, I will pass it off to you now.
Okay, thank you, Jed. Thanks for being a great host for our Grand Rounds series this year, and welcome to today's Grand Rounds, everybody. This is, as Jed said, our last Grand Rounds presentation for this academic year. And as in prior years, we're going to take the summer off, and then we'll come back in the fall with a great new set of Grand Rounds talks and conversations. And I look forward to seeing all of you then. In the meantime, I hope you have a great summer here in the Pacific Northwest or wherever your summer takes you. And now I have the great pleasure of introducing our speaker today, and that is one of our own. Dr. Peter Vitaliano is a psychologist and a tenured professor in our department. He joined the University of Washington almost 50 years ago. I think he told me 49 years ago. That's amazing. That much dedication to one employer for almost a lifetime. That's almost unheard of these days, and I truly, truly appreciate that. Peter earned his PhD in psychology from Syracuse. He did postdoctoral training at Florida State and here at the University of Washington. And he has taught and chaired PhD committees in our department and in the UW Department of Psychology. And if you talk to Peter's students, they have gone on to become professors and deans and other leadership roles at universities really around the world. In his research, Peter has also collaborated internationally. He has worked with people in Europe, in the UK, in Russia, in Canada, in Central America. And he's really widely recognized for his expertise in the area of chronic stress and how it relates to our overall health and mental health. He's developed some really well-known measures of caregiver burden, medical student stress, anger, and coping. And those measures, some of them have been translated into several languages and used in a whole bunch of different research studies. So today I've asked Peter to give us a little overview on the topic of chronic stress and how it relates to psychophysiological outcomes. And I think he's going to use an example of a person who's caring for a spouse with Alzheimer's disease to help illustrate some of that. With that, welcome, Peter. Please all of you join me in extending a warm welcome to Dr. Peter Vitaliano.
Thank you very much, Jürgen, for that really nice introduction. Jürgen already gave you the title of my talk today. It's, I consider being a spouse caregiver for someone with Alzheimer's disease to be a prototypic chronic stressor because of all of the different stimuli and factors that influence spouses who are married to and caring for someone with Alzheimer's disease. They are unrelenting. And I want to just go through my three major objectives, and they are to identify stressors, psychological distress, and physiological dysregulation experienced by spouse caregivers of persons with Alzheimer's disease. And also to look at the caregivers who are at greatest risk for health problems, because this is really important for intervention. And finally, to look at the heterogeneity that exists in caregiver research. And this is specifically even among caregivers for people with Alzheimer's disease, and also to look at the heterogeneity in treatment and also in services. So caregiving is critical to humanity. It fosters meaning in life, it demonstrates compassion, and it also demonstrates the commitment that people have for each other. And this is especially true of family caregivers for persons with Alzheimer's disease. Alzheimer's disease is a progressive degenerative brain disease that lasts anywhere from 3 to 20 years. We don't know the cause. There's no treatment or cure. And it's been called the disease of the 21st century. Now, if you talk to diabetologists, they say diabetes is the disease of the 21st century, but we know that diabetes and AD are very related. So they could have at it. In the United States, there's 6.7 million people with Alzheimer's disease, and by 2030, we expect that there will be 8.5 million. The costs really depend on the source and the estimation methods, but some general estimate is in 2022, it was greater than $321 billion a year. This dwarfs cancer, and it also dwarfs heart disease, which is the #1 killer in the United States. Most of the costs of Alzheimer's disease are borne by family and friend caregivers. They save society billions of dollars a year for uncompensated care, and they enable people with Alzheimer's to live in their homes, which is what they want. Some facts about Alzheimer's disease caregivers: 73% are women, 36% are spouses, 42% are adult children, 64% work outside the home. Spouse caregivers provide a median of 35 hours a week of care, more than caregivers for cancer or heart disease patients. And the experience that they have is there's unrelenting demands, lost personal time, isolation, and financial problems. These experiences are associated with perceived stress and psychological distress. In one meta-analysis of 84 studies, caregivers had 24% higher levels of perceived stress and 28% higher rates of clinical depression than did non-caregivers. And in a meta-analysis that we did of health measures, we compared 23 samples of 1,594 caregivers to 1,478 non-caregivers. And on self-rated illness, caregivers were 16% higher than non-caregivers. On stress hormone levels, they were 23% higher than non-caregivers. And on antibody production, they were 15% lower than non-caregivers. However, we did not observe significant differences in caregivers and non-caregivers in natural killer cell activity, blood pressure, lipids, or glucose. We explained these null results using the diathesis stress model. It says that health outcomes are influenced by interactions of stress exposures with individual vulnerabilities. In English, this means that caregiver stressors are expected to have the greatest impact on vulnerable caregivers. Now, you might say, well, that's obvious, but what researchers do, and we have many examples of that, is not to study the obvious or what's really important. We also included social and personal resources in our working model because they can buffer the effects of stress exposures on health outcomes. So the model we've been using in many different populations besides caregivers is that exposure to stress times vulnerability divided by resources will be able to explain a lot more variability in outcomes such as distress and dysregulation than just exposure to stress by itself. In sum, the diathesis stress model hypothesizes interactions among exposures, vulnerabilities, and resources. So, for example, caregivers with vulnerabilities will exhibit significantly more dysregulation than caregivers without vulnerability and non-caregivers with or without vulnerabilities. So the model that we've used, and I'm not going to be able to show all these data, obviously, the predictors are operationalized as exposure to stressors. They involve not just whether you're a caregiver or not, but life events that happen in your life space, which can be very distressing, like the death of loved ones or financial problems, whatever, and also daily hassles. The vulnerabilities include demographics such as gender, which is a big one, and also the history of having a chronic disease. And because I'm in the House of Medicine all these years, I've been really interested in the history of having a chronic disease. Other types of vulnerabilities are adverse childhood experiences and also personality, which I have a great interest in. But of course, UW is not a hotbed of personality research. So I had to do a lot of this work at Duke, which is. Resources are coping, social supports, and income. What are the model's outcomes? They're operationalized as psychological distress, namely anxiety, depression, and I have a lot of interest in anger, and which is extremely important to health, and physiological dysregulation, cardiovascular, metabolic, and immune function. And then health habits involve diet, exercise, alcohol, tobacco, and drugs, and cognitive processes. How does stress affect cognitive or influence cognitive processes? And we looked at function, and we looked at also speed. We examined these variables in two longitudinal studies that included 205 caregivers living with and caring for a spouse with a diagnosis of possible or probable Alzheimer's disease, and with 205 caregivers who were living with a spouse who could perform activities of daily living and did not have a chronic disease that required full-time care. A lot of the non-caregivers were married to people who had a chronic disease, but they weren't providing full-time care. And you'll see when I show you the hours of care. In study 1, we had 82 care recipients, the people who have diagnosis with Alzheimer's, and 88 non-care recipients. And study 2, 123 care recipients and 117 non-care recipients. And in study 1, the care recipients started out with a mini mental state score of 19.5. And then we followed them for 18 months. And by the second time, they had a score of 13.1. And you could see that the non-care recipients, they were the people married to the non-caregivers. They did not have any decline in mini mental state score. And then if you look over to study 2, we had 123 care recipients and 117 non-care recipients. And the care recipients started out with a score of 17. They dropped to 14.7 a year. This was a year interval, not 18 months. And then another year after that, they dropped to 12.1. But the non-care recipients, they the ones who were married to the non-caregivers, they did not have any drop. Now, if we look at the 410 caregivers and non-caregivers, we can see that the caregivers, their mean age was around 69, and the non-caregivers 68. And then study 2, the groups were a bit older, 71 and 70 for the caregivers and non-caregivers. They had more than a high school, they had a few years of college education, although I have to say that we had some people in the study who were extremely generous and who, well, I can't say too much, but very, 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 very important people that participated in this research. Not that everybody wasn't important, but people who were very, had a lot of notoriety. And then women, which is what you would expect, 63% were in the caregiver group and 69% for the non-caregivers, and then similar percentages in study 2, 61% and 64%. Now, in study 1, the caregivers were already caring for 40 months by the time they entered our study on average. And this is a mean. And then in study 2, the caregivers were already caregiving for 44 months. And you can see that the hours of care increase in the caregivers over time. In the first group, from 6.9 hours a day to 8.1 hours a day at time 2. And that there's hardly any caregiving going on in the non-caregiver group, which is what you would expect. That's the second column. And then the same similar occurrence in study 2. The caregivers start out caring about 8 hours a day on average, and they increase to 9.1 hours. And then the reason why it's 9.0 hours is that we had about 17, which we accounted for, that where they went into nursing homes between time 2 and time 3. At all times, caregivers reported significantly more daily hassles, burden, which is specific to being a caregiver, sleep problems, and depression and anxiety than non-caregivers. So you're not really surprised about the burden since it's geared towards being a caregiver, but the hassles, sleep problems, and depression and anxiety are noteworthy. Given the prolonged elevated levels of stressors and psychological distress, we expected that caregivers would exhibit greater physiological dysregulation and allostatic load. Okay, they would go from allostosis and dysregulation to actual load than non-caregivers. And I'll show you what I mean by that. So these are two slides side by side. The first slide is for time 1, and the second slide is for time 3. And these are the plots are for urinary cortisol at daytime and at nighttime. And I thank the wonderful school, UW School of Nursing, who did the assays for us, Margaret Heitkamper and her lab. What we show is that the blue line are caregivers, the green line are non-caregivers. And you could see that thank Mother Nature, that both the caregivers and the non-caregiver controls, the blue line and the green line, they both go down from day to night, which is what you would expect. And that's at time 1. And then if you go over to time 3, the neck on the right side, you see the same thing happens between the caregivers are significantly higher than the non-caregivers at day and night. So at both day and night, at both time 1 and time 3, the caregivers are higher both in the daytime and the nighttime. And another way to look at this, which shows how everybody increases, both the caregivers and the non-caregivers, they're 2 years older, both because this is 2 years later. And you see that the caregivers go up in their cortisol levels, and so do the non-caregivers, the green bar. But caregivers are always higher than the non-caregivers at daytime and at nighttime. So the cortisol levels suggested greater allostatic load in caregivers relative to non-caregivers. However, we were also interested in psychological distress and physiological dysregulation, as they could influence the long-term health of caregivers. The physio dysregulation is very, very important to our department, but also to the rest of the med school, cardiology, diabetology, et cetera. And then, of course, psychological distress is very important to psychiatrists as well as clinical psychologists and social workers. So we use the diathesis stress model to hypothesize that caregivers who have vulnerabilities would exhibit elevated distress and dysregulation specific to their vulnerabilities. And the vulnerabilities that we looked at were, do you have major depression disorder? Do you have a history of cancer? Do you have heart disease? Or are you hypertensive? So do you have hypertension? So those are the vulnerabilities. And so we looked at them, and these are the physiological measures that we looked at in caregivers and non-caregivers with and without those vulnerabilities. We looked at, in people with cancer, natural killer cell activity. This is the ability of your natural killer cells to kill tumor cells. Of course, this is done in the test tube. Ability of natural killer cells to kill tumor cells. And we know that people with cancer histories tend to have lower natural killer cell activity, but there's other factors involved, and we're going to talk about those. In the metabolic syndrome, that's the sum of diabetes, do you have it or not? Obesity, yes, no. Hypertension, yes, no. And lipidemia. This is a very powerful predictor of heart disease. And we looked at people, their metabolic syndrome levels in those who have heart disease and don't, that are caregivers and not caregivers. And finally, we looked at blood pressure reactivity. This is the increase in blood pressure from rest when you're listening to music, which to me would have been a stressor. But when I did this, I was a lot younger. Maybe now I'd like that kind of music. I don't know. I still don't. But anyway, it's an increase in blood pressure from when you're resting to when we expose you to a stressor. And this blood pressure reactivity is a very powerful predictor of the development of hypertension. Now, this slide is very important, so I want to explain it because it'll really help to explain the slides that I'm going to be showing you. In the left column, far left column, those are the indicators: depression, natural killer cell activity, metabolic syndrome, and systolic blood pressure reactivity. And it turns out that those are worse off. Caregivers are worse off than non-caregivers on those things, but only if they have a vulnerability. And in the case of depression, current depression, it's major depression disorder history. And I should put generalized anxiety disorder there as well, because we were hard up and we didn't have enough people. So we looked at MDD and GAD. And for natural killer cell activity, we looked at people who have cancer histories, metabolic syndrome, coronary disease, and systolic blood pressure, hypertension. What I want you to look at is the far right column. Caregivers are not different than non-caregivers on current depression, natural killer cell activity, metabolic syndrome, systolic blood pressure, if they don't have those vulnerabilities. But if you have a chronic disease or illness like MDD or GAD, then caregivers are worse than non-caregivers on current depression and generalized anxiety disorder. On cancer history, the same with natural killer cell activity. On coronary disease, metabolic syndrome, that if caregivers are worse off than non-caregivers if they have coronary disease, and then for hypertension. So now I'll just show these to you. I try to make this slide colorful to appease the bird, and it's the ugliest slide I have, but it's pretty straightforward if you look at the forest and not the trees. The forest is that there's two, the two columns are caregivers and non-caregivers, and the rows are, do you have a lifetime history of major depression disorder or generalized anxiety, or do you not have a lifetime history of MDD or GAD? And I want to just say that these data are pretty old, and the person who did all the interviews is one of the most famous people that our department's ever had, who was an absolutely wonderful colleague who's passed. And he was a junior faculty member, and he not only did some of the interviews, but he trained our clinical psychologists to do them. And the caregivers, you can see that there's 26 caregivers who have a lifetime history of MDD or GAD, and there's 23 non-caregivers, the far right column, that have a lifetime history of MDD or GAD. And then there's 56 caregivers who don't have a lifetime history, and there's 63 non-caregivers who don't have a lifetime history. But look at the purple numbers. I mean, they just jump at you. 19 out of the 26 caregivers who have a lifetime history of MDD have current major depression and GAD. Only 7 of the non-caregivers who have a lifetime history of major depression and GAD have current major depression. And of course, in the second row, there's very few caregivers or non-caregivers who have current major depression disorder, and they don't have a lifetime history. So it's really the lifetime history and being a caregiver together that is, again, as I said before, it's like mixing oil and fire. In terms of natural killer cell activity, we have the percentage of natural killer cells in blood that kill tumor cells. Of course, this is done in test tubes. That killed the tumor cells. And I want you to look at the second part of the graph, the people with cancer histories. You could see that caregivers are significantly lower than controls, the non-caregivers, if they have a history of cancer. If they don't have a history of cancer, on the left side of the graph, there's no differences between caregivers and non-caregivers. Indeed, caregivers with a cancer history are much lower than the other 3 groups together. This was one of the most interesting sub-studies that we did. We took the caregivers and the non-caregivers were kind enough to come into UW. We had a lot of office space on the 15th floor, and we had a nice quiet room where we could administer this study to look at blood pressure reactivity. So all of these folks in the emotional stressor, which is the strike bar, they were asked to speak for 5 minutes without interruption about the kind of spouse that their spouse is. And if you know this, this is the 5-minute speech sample, which has been used to look at caregivers of people with schizophrenia. And we actually did a lot of work on this and helped them at UCLA, who developed the 5-minute speech sample. And the yellow bars are a cognitive stressor. That is using an arithmetic test that they had to give verbal responses to because speaking increases your blood pressure, and the emotional tasks involve speaking. So we had to control for that. And this shows the increase in blood pressure from rest. And I showed this a few times, and I look at this and I said, how the heck did we ever do this? I don't know if human subjects would even let us do this. I mean, this is like a huge increase in blood pressure from rest in the people who were talking about their spouse for 5 minutes without interruption. You could see that the hypertensive caregivers are significantly higher than the hypertensive controls, which are the next 2 bars. They're significantly higher than the normotensive caregivers, and they're significantly higher than the normotensive controls. It's really the combination of being a caregiver and being hypertensive that really is volatile. Importantly, caregivers with hypertension also took significantly longer to recover and return to baseline than did the non-caregivers with hypertension. So we provided a lot of feedback to the docs who were kind enough, with the permission of the caregivers and the non-caregivers, to send us the medical records. This is the newer study, and this study is really kind of cool because we actually used 24-hour ambulatory blood pressure monitors so that we could look at blood pressure when they were in the home. So we sent folks to the homes of the caregivers so we could make sure that they knew how to wear the monitors, and we asked them to wear them for 24 hours. This is for the 12 hours during nighttime, from 9 p.m. at night to 9 a.m. the following morning. And you could see the purple line that in year one, caregivers with hypertension, which is the purple line, they were very similar to non-caregivers with hypertension, which is the turquoise line. But you could see that over the next 2 years, caregivers with hypertension really increased dramatically compared to non-caregivers with hypertension. And the caregivers that were normotensive, the red line, at year one, they increased enough over the 2 years that they now look like, that is, caregivers who are normotensive at year one now look like non-caregivers who are hypertensive. So finally, this is the interaction between being a caregiver and having heart disease. And you can see here that the caregivers who have heart disease, which is the black bar, the black bar, they are significantly higher than the other three groups on the number of members of the metabolic syndrome added together than the other three groups. And this is true not only at time one, but also at time two, which in this particular study was 18 months later. Now, I had the honor student in 2002 that was one of the most brilliant students I've had, and I've had 700 or 800 undergrads since I've been here. And she's just a wonderful person, a Canadian who had moved to Canada and was Chinese Canadian. And she is now the dean at the Chinese University of Hong Kong, one of the deans. And she sent me these results in November before the election, and I hope we could continue to work together on this. This is from the Chinese Health and Retirement Study. These are 2,875 grandparents, and we did the same thing with caregivers and non-caregivers who were hypertensive and non-hypertensive and normotensive, and also with heart disease and diabetes as the vulnerabilities. You could see that for diastolic blood pressure, hypertensive caregivers are greater than the other three combinations. For triglycerides, caregivers who have heart disease are significantly higher than the other three groups. And on glycosylated hemoglobin, the caregivers with diabetes are significantly higher than the other three combinations of folks who have diabetes and non-diabetes, caregivers and non-caregivers. So it's the same pattern holding up with big samples. Now, I want to conclude in the next slides, although I do have a few more. Since this is kind of a retirement talk, I get to do whatever I want. So anyway, I wanted to rediscover some ancient research that we did many years ago. And I wanted to rediscover ancient research to recommend new research. And I entitled this Stress, Gums, and the Brain. In 2006, the Surgeon General of the United States proclaimed the mouth is part of the body and should be studied in medicine. I remember back then reading that and saying to myself, did he really say that? Did he just say that? Yes, I have it in writing and I could send it to you. He said the mouth is part of the body and it should be studied in medicine in 2006. In 2005, our group found that 17% of caregivers reported having bleeding gums. This contrasted with 8% of matched non-caregivers, matched on age and gender, education, et cetera, and income, and also race, because we have African-American caregivers and African-American non-caregivers. This difference was mediated by elevated levels of depressed mood, insulin, glucose, and obesity. That helped to explain this difference between caregivers and non-caregivers in the higher rates of bleeding gums in caregivers. We also observed in a whole series of papers from 2003 all the way up to 2016 that caregivers experienced greater 2-year decline in vocabulary, trails, and digit symbol test scores. And these were mediated by depressed mood and metabolic variables. So the same variables that mediated the decline in cognition also mediated the elevated levels of bleeding gums. And a whole series of studies have replicated our research on cognition in caregivers, but primarily, this is really important, primarily in caregivers of persons with dementia, not caregivers of people with heart disease or cancer. Recent research, this is why I said I'm dusting off old research to talk about new research. All of these are new studies. Recent research has found relationships between periodontal disease and cognition and brain function. Periodontal disease is associated with cognitive decline and dementia in 47 studies that were reviewed by Asher et al. In 2022. Yang et al., who are at Emory and also have asked about collaborating, they found that periodontal disease bacteria is associated with poor cognition in Black caregivers. They also, and by the way, they've only studied Black caregivers. Rivier et al. In 2025, they found that 14% of 40,000 adults in the UK reported poor oral health. 14% of 40,000 UK adults reported poor oral health. And this is also associated with neuroimaging risk factors for stroke and dementia. Finally, Zhang et al., she is this brilliant. Um, uh, I don't know what she. I think she's a neurologist. I don't think she's a psychiatrist. She's contacted me. She's a professor at Harvard. She would love to collaborate with people at UW. So if there's anybody that wants to, she flies from Boston to. She's at Harvard. She flies from Boston to Seattle and then to Beijing. And she's a really nice person. And she's found that oral and gut microbiota in AD caregivers of people with Alzheimer's disease, resembles those of their spouses, those who have the care recipients. And she's saying, don't shoot me for this because this is a little over my head, that this indicates some possible transmission of microbiota. So I'll let the people who really know about this stuff, like you could, say whatever you want, but I think it's really interesting. So what are the implications, the theory, the research, and the treatment that are relevant to this? Some researchers, and I'd like to say more researchers than not, are starting to claim that caregivers are not at higher risk for health problems. I hardly ever see people who are in medicine say that caregivers are not at higher risk for health problems. And I won't want to say who these people are and what their disciplines are that are saying that caregivers are not at higher risk for health problems. But they did not study caregivers of persons with Alzheimer's disease. And they also have ignored vulnerabilities that exacerbate the influence of stress exposures. So I and my undergraduates have been trying to understand heterogeneous findings. Thus far, we have examined 223 caregiver studies of several types of care recipients, not just care recipients who have Alzheimer's disease. The samples across all those 222 studies involve almost 18 million people from 45 countries. And I worked really hard to get studies from South America and studies from Africa. The vast majority of these studies did not assess vulnerabilities or resources. They act like that this is people are being exposed in a test tube without any kind of other exposures. This is also true of interventions. I had the privilege of doing a paper with 3 deans at nursing schools in California, and we did a systematic review of caregiver interventions. And we evaluated 2,700 articles, 197 had systematic reviews, but these reviews didn't give actual retrievable data, only 33 did. And we studied those systematic reviews, and they had limited vulnerability data, limited data on gender, race, and SES. And the interventions did not consider interrelationships between caregiving, vulnerabilities, and health. And of course, we argued that interventions should target and adapt methods to diverse conditions and populations. So not to be a hypocrite, these same folks at UC Davis are managing a huge study and you could say somewhat of an intervention that exists in the state of California. California has 6.7 million caregivers. It has 11 caregiver resource centers. 11 caregiver resources. They provide education, they provide referrals, they provide respite, they provide vouchers, they provide legal and financial advice. UC Davis collects data on the caregivers and evaluates these CRCs, these caregiver resource centers, for their services and their supports and for their care provided and for their health and for the services that they provide. In 2022 and 2023, these resource centers reached more than 900,000 people, and they provided 5,782 assessments, and they created a database of 121,000 unique and heterogeneous caregivers. They provided services to 14,000 caregivers, 158,000 consultations and counseling, legal assistance, outreach, education, and almost 13,000 hours of respite. In sum, caregiving for a spouse with AD is a prototypic chronic stressor. I am indebted to the caregivers and non-caregivers who gave their precious time to participate in this work. As a thank you, all the caregivers and non-caregivers were provided feedback and results that were shared with their primary care physicians. Rosalind Carter was a caregiver, and so was another First Lady, a caregiver. Two very, very different personalities and two prominent caregivers. They got a lot of publicity for being caregivers. I'll quote Rosalind Carter, who said, "There's only four kinds of people in the world: those who have been caregivers, those who are current caregivers, those who will be caregivers, and those who will need caregivers." So since I joined this department, I've had the luxury of studying communal disasters, psychiatric diagnoses, of course, with great colleagues, medical diagnoses, cancer, heart disease. I studied air traffic controllers, and the two groups that I've had some of the most interest and actual pleasure working with were medical students and family caregivers. It turns out that those medical students that I studied are in their 60s now. Yep, they were in the classes of 1983, 4, and 5, and 6. And there's 600 of them. So if anybody wants to do an amazing, amazing longitudinal study to look at the interface of people who provide formal care, because many of these folks have been family caregivers as well. So they also were formal caregivers, physicians, and also informal caregivers. And I think that we should ask the dean for funding to try to follow them, and I know how we can do it. So, and I'm not Big Brother. So if anybody wants to do that, we should do that. I really have to thank these people, these wonderful people. These are the first students that are on the list, the people in orange, they were all my students. So we have Joan Russo, a fantastic professor in our department, Heather Young, who was a student here, who became the first dean of UC Davis Nursing School and is still a professor there. She's retired from being the dean. Jianping Zhang, who's head of psychiatry at Glen Oaks Hospital, James Scanlon, research scientist Helene Fung, who I mentioned before. And then I really have to thank these colleagues and collaborators who were absolutely, have been wonderful. Wayne Caton, Sue Borson, Margaret Heitkamper, who was a retired professor of nursing, Earl Hirsch, who's one of the famous diabetologists in the United States, and Jin Yu, who is at Wuhan University. So I'm going to shut up and stop and share and then see what happens.
All right, well, the first thing that happens is I returned again. So thank you very much for that presentation today. What do we have here? About 4 or 5 minutes for questions. So folks online, if anybody has any questions, go ahead and type those into the Q&A feature. I'll read those out loud for everybody. While we're waiting for that, we'll welcome back Jürgen, who just joined us again.
Okay, let me not start with a question, but just a great big thank you to Peter for a really superb presentation of a tremendous body of research today. And really for all of the contributions that you have made to UW, to our department, and to the field. So
thank you.
Amazing.
That means a lot. Thank you very much.
Amazing tour de force, and not just looking backwards, but looking forwards and thinking about some really important new opportunities. And longitudinal studies are hard to do, but I like the challenge you're giving us with saying, what could we learn from the folks that you studied, in the early 1980s.
Yeah. And we still have a lot of data. So if anyone wants to participate or even talk about, join a conference call if you're interested and you do clinical work and you want to join a conference call with us from the School of Nursing at UC Davis to talk about those CRCs. Not that you don't do good clinical work. I mean, I'm just saying we could all learn from each other.
The one thing I will say is, in our clinical work, we tend to be very focused on the patient in front of us. It can be more challenging for us to start engaging a caregiver. We don't get our financial systems, our clinical systems make that challenging. I've had a couple of interesting projects where I've tried to work with people when a spouse comes in for a visit and the patient identified has depression, to say, what would it take to involve the spouse in supporting them and maybe making them more of a partner in the care. And that is a beautiful thing. It's actually work I've done with folks at UC Davis. And everybody has some scary experience where they say, I asked the spouse in the middle of a visit and the spouse said, you know what? I'm not the patient. This is the patient. We've had a pretty difficult relationship. Good luck. And said, every doctor that I've worked with said, I have one of those experiences. I'd never do it again. But I think it's a really important thing for us to think about. How do we really think beyond that one person who's sitting in front of us, right?
Yeah.
All right, so I'm seeing a couple of things pop up here in the chat. Someone is asking, Dr. Vitaliano, are you willing to share your slides with them?
Oh, yeah. So you give the, doesn't the department put these in a repository?
We will be posting on the video recording, but we won't post the slides unless we have your permission. So if you're willing to do that, we can share.
Yes.
Okay, so if you could put your email address in here, Lone, then we'll go ahead and share those with you.
Okay.
Okay, so here's a question that just okay, a couple questions just popped up here. So thank you very much. Let me go over here. Okay, so do you have any hypotheses of what you would find with the longitudinal study looking at formal caregivers who are or have been informal caregivers as well?
Well, if you look at the AMA ethics, people, well, first of all, are they, the people who were on my study that were formal caregivers, namely mostly physicians that were in my study, they were retired. Okay. But if you're still a physician, if you look at the AMA, I think it's pretty clear that you're able to provide guidance. You're able to do a lot of legwork and support, but I don't think you're allowed to treat. So can somebody who's a physician please verify that?
Yep, that's the case. You're right.
But I don't know, did I answer the question?
No, I think the question maybe was, what's your hypothesis? If you got to study these folks again, 40 years later, what do you think you'd find? I think that maybe was the question.
Oh, thank you. Okay, so I actually have data from, so the reason why I did the study with the medical students is because in 1982, we had 2 suicides in the undergraduates. We had a suicide in the psychiatry residency program, and we had a murder of someone who was a postdoc who murdered a professor in their lab. And the dean obviously got freaked out, and he asked our department, the chair, would somebody study these medical students and try to figure out what's going on? So I actually, that was my whole career at the beginning, was to get grants. And so I have biology, I have blood pressure reactivity. I have, well, not reactivity. I have blood pressure. I have lipids, and I have a lot of psychosocial data on depression, anxiety, social supports, etc., on these folks when they were medical students. I would say that people who have, I think anger is one of the most interesting emotions, and we spend so much time, a lot on anxiety and depression. I think that anger is super really important to health. And I would say that those students who were really high on anger at that time may have more problems now if we looked at their development of hypertension. That's one hypothesis.
All right, great. So we're after 1 o'clock here. We have one more question, so we will do this last question here. But before we go, I just wanted to remind everyone, if you have additional questions, if you put your email address in the chat, we'll make sure that gets to Dr. Battagliano, and we can continue this online afterwards. But for the last question here, are you aware of any interventions designed to facilitate the mental health of informal caregivers?
Oh my God. I had to cut down my slides in order to, because I wanted to leave some time and I didn't want to inundate you. I have so much stuff. I have some slides that I could send you that I didn't include that list the major interventions that have been done with caregivers, cognitive behavioral therapy, etc. And I would be happy to send that to you.
All right. So yeah, go ahead and put your email, and there it is. All right. Let me get a screenshot of that, and we're good. So thank you very much again for being here and ending our Grand Round series for the academic year. Folks online, thanks for watching. We'll be back on September 12th, I believe, will be our return.